Good morning. Today we are going to discuss congenital heart disease, in which we are going to cover congenital acyanotic heart disease, and the defect which we are going to cover today is ventricular septal defect. And we all know that the ventricular septal defect is the most common CHD occurring once in 500 live births. This defect may be isolated or it may be a part of complex congenital heart disease. Congenital VSD occurs as a result of incomplete septation of the ventricles. Embryologically, the IVS has a membranous and a muscular portion. And the muscular portion is further divided into inflow, trabecular, and outflow portions. Most congenital defects are perimembranous, occurring at the junction of membranous and muscular portions of the septum. As depicted here, you can nicely see in this cartoon that this is your interventricular septum, this is your left ventricle, this is your right ventricle, and there is a defect in the septum in the perimembranous area, and there is a shunt going from left ventricle into the right ventricle. Regarding the clinical features of the VSD, flow from the high pressure LV to the low pressure RV during systole produces a pansystolic murmur, usually best heard in the left sternal edge but radiating all over the precordium. A small defect often produces a loud murmur, what we classically say as malady rosa, in the absence of other hemodynamic disturbances. Conversely, a large defect produces a softer murmur, particularly if pressure in the RV is increased. This may be found septal defects into the aorta immediately after birth, while pulmonary vascular resistance remains high, or when the shunt is reversed, it is called Eisenmenger syndrome. Congenital VSD may present as cardiac failure in infants, as a murmur with only minor hemodynamic disturbance in older children or adults, or rarely it is going into the Eisenmenger and presenting with the Eisenmenger syndrome. In a proportion of infants, the murmur becomes quieter or disappears due to the spontaneous closure of the defect. And if the defect is large, it may be complicated by heart failure. It is usually absent in the immediate postnatal period and becomes apparent only in first 4 to 6 weeks of life. In addition to the murmur, there is a prominent parasternal pulsation. Patient might be tachypneic, and there might be indrawing of the lower ribs on inspiration as a part of failure. And this is the two-dimensional echocardiography picture. It is the parasternal long axis view, and you can see here there is a large perimembranous VSD communicating left ventricle and right ventricle. And it is the, again, color flow mapping of the same defect, and you can see here the flow is passing from left ventricle into the right ventricle, and there is an increased flow across the pulmonary artery. And here again, this is the perimembranous VSD, and you can see here the flow is going from left ventricle into the right ventricle. This is a Doppler interrogation, and you can see there is a jet across the VSD producing a gradient. Investigation, and of course, the most important investigation is Doppler echocardiography, and it should be performed since it helps to identify the small defects that are not hemodynamically significant and are likely to close spontaneously. So, echocardiography with Doppler and color flow mapping should be involved in screening, not only diagnosing VSD but to detect the signs of pulmonary hypertension with the larger defects. Of course, the routine investigation, chest x ray, will reveal the pulmonary overflow, and ECG will show bilateral ventricular hypertrophy. Regarding the management of VSD, the small VSD require no specific treatment, and if there is a cardiac failure in infancy, they should initially be treated medically with diuretics and a plus minus role of digoxin. Persistent failure is an indication for surgical repair of VSD, or this could be closed by cath interventions as well as by surgical interventions. If serial ECG and echocardiography suggest that pulmonary hypertension is developing, then the VSD should be closed as early as possible. Depending upon the size of the defect, you can utilize a cath-based intervention or surgical. Surgical closure of VSD is fully developed Eisenmenger syndrome is contraindicated, and in that scenario, the only option left for the patient is cardiopulmonary transplant. Long-term prognosis is generally very good in these patients, except the exception is Eisenmenger syndrome, when death normally occurs in the second and third decade of life, but a few individuals survive to the fifth decade without transplantation. Regarding the prophylaxis of infective endocarditis in VSD, we all aware now, as per current guidelines, we don't recommend prophylaxis for isolated VSD patients. We only recommend a good orodontal hygiene. Thanks for your kind attention, and thank you.